It's very rare for us to be able to get these medications covered for weight loss. Our health system is very much a reactionary health system rather than a proactive health system. Obesity truly is a disease, just like high blood pressure, just like diabetes. It's there and it's staying there. It's something that you have to constantly control every day. And therefore, if you're starting a medication for high blood pressure and diabetes, it makes sense that if you're starting a medication for obesity, that it's something that you stay on indefinitely. When you're taking it purely for weight loss, a lot of people who are motivated, they'll go out and they do everything, but their body just keeps fighting them and they're not shedding the weight. So this medication comes in to help that. There are also people who are not motivated enough and they need kick, something to just light a fire. And this medication can be that fire. Medicine,
law, friendship. This is Dr. Long and Lawyer Nik. You're listening to the Medico-Legal Brief.
One doctor, one lawyer, and a whole lot of gray area.
Welcome back to the Medico-Legal Brief, where medicine meets the law. I'm Lawyer Nik. I'm with Dr. Long. If you haven't already, like, subscribe, follow. We've been on YouTube and Spotify for a few months now, and we've had pretty good engagement with our followers and our subscribers, so feel free to join our community. With that, Dr. Long, we have a pretty interesting topic today. We are going to dive into the fad, the craze, the GLP-1. So to start, what is GLP-1? What's going on with it in the world right now?
I'm sure a lot of people have heard about what a GLP-1 is. It's the injectables. We see a lot of commercials on the amazing effects on weight loss, the great control for diabetes. This truly is a revolutionary drug that has come out recently over the last couple of years. So just a brief background on what GLP-1 is. GLP-1 stands for glucagon like peptide 1. So it's a specific type of hormone that then enacts on your body and gives us the result that we're looking for. The effects that we're looking for this specific drug is it's going to act majority of the time will be on your pancreas. Your pancreas is that main organ that will control your blood sugars. So your pancreas is smart enough to know that if you are running low on sugars, it's going to release certain hormones to then allow more sugar to be released. So you have glucose or sugar constantly stored in your body. It's stored in your muscles, your fat, all sorts of tissue in your body. And so when glucagon is released, then your body knows to release that sugar or glucose so that your system has enough sugar to floating around. Now, the opposite or the inverse of that would be the release of insulin. So the insulin is released when your body finds a signal that there's too much sugar or too much glucose floating around in the body. And so then insulin is released, which then signals to your body that the cells need to absorb the glucose into the tissue instead and store it for future use. But not only for storage, but also to utilize it. So whether you are out exercising, going for a long walk, insulin needs to be able to produce so that it can feed your cells, feed your muscles, feed your tissues so that you can operate. Other effects that the GLP-1s have on your body is it will slow down your gastric emptying. Basically, it slows down your intestines. It's not going to metabolize, process everything as quickly as it normally would. And so things slow down, you feel more full, therefore your appetite gets decreased as well. So that's a very surface level of what a GLP-1 does and why it's so beneficial.
And the GLP-1s, like, they started off to help with type 2 diabetes. That's where they originated from.
Correct. Yep. So the original use of GLP-1s were for type 2 diabetes specifically. But of course, just like any other manufacturer out there or any other industry, when it comes out and you realize that there's another utilization or another benefit to it, then they're going to try to rebrand and sell it and market for that other aspect as well. So as we go through this podcast, we're going to be talking about the original diabetic versions, and then the rebranded versions, which are specifically for weight loss. And every single day or every single month, there's new FDA approvals for other types of medical diagnoses that these could be used for as well.
We talked about that when we had a session where we were talking about street drugs and how street drugs came to be, because at first were pharmaceuticals, and then obviously people saw the side effects and ran with it. But this specifically reminds me of the story behind Viagra, where wasn't Viagra initially like a blood pressure medication, and then everyone realized the side effects of it and it was rebranded like what we're seeing here?
Not blood pressure, but pulmonary hypertension. That was originally used for other reasons. And yes, one of the benefits or one of the side effects we say is you get excited.
From a Viagra standpoint, is that still used as, would you call it, pulmonary?
Yep. You can still utilize it as pulmonary hypertension treatment as well as for erectile dysfunction.
Okay, so it hasn't completely gone to the other side. It still has its use, and it's still respected as that initial medication, which is what we see here, where as a type 2 diabetic, you would be looking for the same medication, and it would be okay to use, I would assume, correct me if I'm wrong, be okay to use these branded pharmaceuticals that are marketed towards the weight loss that would still be okay to use as far as type 2 diabetes.
If you're looking back down to the molecule, it's the exact same molecule. But of course, here in the US, it comes down to what your insurance will approve. Your physician may want a specific brand because it works better, the data is better. But if your insurance is going to say, no, you have to try this other option first or this other version of it first, then you do. But we're at the whims of what your insurance company will allow and what they will cover. And it changes every year.
Okay, so let's go back to the beginning. We've discussed how GLP-1s came to be, the use at least for diabetics. Do we want to start there? Do you want to give a brief history of how it was utilized and then how we've made this journey to where we're at today, where it's on the cover of every magazine, it's on every YouTube video, so on?
I will do you one better, and let's talk about diabetes and how it's turned into this epidemic in the US. Not only diabetes, but obesity as well. So those two go hand in hand sometimes. The people who are more likely to be overweight and obese are at higher risk of developing type 2 diabetes. Now, the difference between type 1 and type 2 is basically how much function of your pancreas there is. Type 1 is usually when your pancreas is completely kaput. There's no longer any ability to create any hormones like insulin to reduce your blood sugars. So you usually find out about type 1 diabetes at a very young age when it suddenly shuts down. Usually it's the scenario we learn about is usually a 8, 9-year-old who goes into the hospital, completely lethargic, makes no sense. They pass out, they're very fatigued, and you do blood work and you find out that the sugars are super, super high. And so that's usually how you diagnose type 1. Now, type 2 is more of a slow process. It's something that takes years, time, and it's very dependent on your lifestyle. So whether you are inactive, a sedentary lifestyle, your eating habits, if you're eating a lot of carbs and starches, sugars, those are all things that will increase your risk of developing type 2 diabetes. Now, there is a genetic component to type 2 diabetes as well. And again, it's based on the fact that if your parents, grandparents have type 2 diabetes, you are more likely to develop it. And so this is where it's really important that you have that relationship with your primary care physician, because then you can talk about what do you do, what can you do to help avoid or decrease the risk of developing those diseases.
And when you get either type 1 or type 2 diabetes, I assume that there's no cure for it. You just have to live with it forever.
Correct. A very good question. So diabetes come in different stages. So one, if your sugars or your levels are within the normal range, then you're considered not diabetic. But then there is a middle range where it's in between normal, but you're not quite diabetic. And that's called the pre-diabetic range or pre-diabetes. And the way we diagnose this is through blood work. It's either a fasting blood glucose or what we call a hemoglobin A1C. And so that is a blood test that averages your last 3 months of sugars. And so there are certain ranges that will determine that pre-diabetic range. Pre-diabetes could be reversed if you made the appropriate lifestyle changes. It could be reversed and go down to a normal range. However, once you hit diabetes, that unfortunately is now stuck with you lifelong, because the difference between a diabetic versus a person that does not have diabetes is you can go out and eat a full cake, a person that doesn't have diabetes, and their sugars will go up, but it will re-regulate very quickly and very easily by their own body. Whereas a diabetic, the sugar will overcome the body, and therefore the sugars will shoot up into the 400s or 500s. And so that's where medications come into play.
That's very interesting. My grandfather had diabetes. I want to say that he was type 2 diabetic. And I remember even towards the end of his life, which is when I was starting to become an adult, the hey, he can't drink that. Hey, he should not have that. Hey, let's not give grandpa cake, because if we give grandpa cake, like, he's a diabetic, we all need to be aware of it and kind of help out that situation. So it is, to your point, a relationship with your eating habits and your lifestyle. The one thing I did notice, and you mentioned this though, is my grandfather wasn't obese. So is there a causal link between the two, or can you have one without the other? How does that work?
You can absolutely have one or the other. Like I said, obesity does not lead to diabetes, but it does increase your risk of diabetes. So just like any diagnosis out there, there are always risk factors that push you closer to that issue. So heart disease, if you are male, if you're older, if you smoke, if you drink, those are all things that increase your risk. It doesn't mean that all alcoholics or all smokers have heart disease, but they're more likely to develop it. So same thing with diabetes is if you are obese, you're more likely to develop the diagnosis. And the reason being is because one, your pancreas has to work a little harder. Two, fat can sometimes develop what we call insulin resistance, meaning your body is creating insulin, but your fatty tissue is not listening to the signals that the insulin is signaling. Therefore, the sugar continues to float around in your bloodstream, which is not a good thing.
And then I'm going to use the medical terminology that we've discussed. So, type 2 diabetic, what is the lifelong prognosis? Where does it eventually lead to? See, I learned.
Yes, you did. Very good, Lawyer Nik. So the prognosis for type 2 diabetes nowadays is actually very good as long as it is well controlled and maintained, whether that's through diet or whether that's through medications. And that's why this discussion about GLP-1s is so important because it truly has come out and changed the entire landscape on how we manage diabetes. But if you are diagnosed with diabetes early and you control it early, you can absolutely live to where your normal life expectancy would have gone 80, 90, 100. Now, if you have uncontrolled diabetes, you're more likely to have chronic issues, right? So you're going to more likely have renal disease or kidney issues. You're going to have vision changes, blurry vision, neuropathy. You may be more likely to have amputations. So a lot more risks and a lot more health issues come along with uncontrolled diabetes, which is why it's something that we really keep a really close eye out on regularly. So my diabetics that are not controlled, I usually have to see them every 3 to 6 months. Whereas my very controlled diabetics, I usually just have to see once a year.
The not controlled is them basically not controlling their approach to managing it, right?
Not controlled is whether one, they're not eating appropriately, they're not losing their weight, or they're not exercising, or they're not willing to take medication.
Yeah. Okay. My question, you touched on it. My next question is going to be, what is with the amputations? Why does this lead to a possible amputation in the future?
When sugar floats around in your body, that's not what your body wants. It's not the homeostasis that it likes. So sugar will then float into the very small blood vessels as well as the very small nerve endings of your system, which then causes it to become damaged. And that's why you have neuropathy, and that's why you have a lot of peripheral vascular disease where you start having really cold limbs or the blood vessels start to deteriorate and they're therefore not able to bring blood flow to the extremities. And so then you're at risk for losing that extremity, that finger, that toe, because of that. It usually is a combination of not only the loss of blood flow, but it's also usually due to some sort of injury, puncture wound that maybe they didn't notice. And then there's an infection that takes over and it really does a lot of damage. That combination in a scenario that then causes the amputation.
Obviously, healthy lifestyle, you taking care of yourself. Now GLP-1 is put in place. At what point are you prescribing GLP-1 and what are you looking for as far as diabetic side effects before we move into the weight loss features of the drug?
Medications are great. I will always advocate for natural options first, like lifestyle changes, making those modifications where you can, working on food choices. I never say dieting because dieting truly is more of a fad. You're going to diet for a short period and then you're going to fall off that train. So I always say we want to make small changes to your food, your eating habits, your food habits that will be sustainable, whether that is looking at eating smaller portions. That's usually easier for people to comprehend. So I say you can still eat your pizza, you can still eat your cake, but we're going to limit how much you're eating. Instead of eating the whole cake, you're going to eat one slice only. If you're going to eat pizza, we're going to do just one slice. Or maybe we're doing a sandwich. Instead of doing 2 slices of bread, we're going to do 1 slice of bread, but keep all the protein and lettuce and tomatoes all the same. So small changes like that will then change the psychology around food. And then the next step would be then to exercise. The more that you exercise, the more that your body will use up the glucose. Therefore, it does not float around. So the more that you can do that, it naturally will lower your sugars. Finally, then we go into medications. Now, if you've done all those things, you're completely healthy, and your body just says, you know what, we need a little extra help, then we usually start with first line medication, which is called metformin. That's one of our oldest drugs out there, but that is still the gold standard to start with. And then now the GLP-1s would be second in line. So if you are not controlled on metformin, then we start talking about a GLP-1.
Back to the first couple minutes of the podcast. What exactly is GLP-1 doing for the diabetic when they get the shot? And is it a weekly dose or is it a daily dose?
GLP-1s come in different formulations. So the majority of what we hear are those injectables. They originally came out with once a day injections, but now the majority of prescriptions are the weekly injections. So other brands have come out with competitors that have done weekly. We also do have a single oral brand that you can take an oral pill every day. It's not going to be as effective, but it still does a fairly good job. But we talked about already how the medication acts on the body. And again, it's going to help increase your insulin. So releasing a little bit more insulin from your pancreas. It's going to lower the release of glucagon. And remember that glucagon hormone is what will release glucose from your tissues. That's usually when you're in a low sugar state. But in this situation, you're in a high state. So we really don't want to release that glucagon hormone. And then the other thing is that gastric slowing. If it slows down your intestines, then you're not going to feel as hungry. So you're not going to want to eat as much. The medication essentially turns into your own personal trainer because it's going to make you feel sick when you eat too much or when you're eating the wrong things.
Yeah, I don't want to feel sick. I've had my own sort of like gastro issues throughout life, and it's never fun, when you're feeling pain in your gut. But at the same time, I've known individuals that non-diabetics that are actually taking it for weight loss, and it's actually been kind of wild, just the results that occur. So this might be a good point to transition into, this weight loss GLP-1 phase. Like, what happened? How did this whole thing come to be? Because I feel like it was like a snap of the finger and every other person was either talking to their doctor about it or they were already on their way to take it. And I felt, I don't know if you've dealt with patients in this manner, but I felt like at first it was a little hush hush. People were keeping it on the down low, that they didn't really want to talk about taking an injectable as a weight loss. And now it's like, oh yeah, I'm on that. Oh yeah, I'm taking it too. And now everybody's proud of it and the results are nice. And so what led to this whole craze? Where did it start? How did it happen?
Originally, it was for diabetics. And then the companies noticed that the diabetics were losing a ton of weight. So then that's where they rebranded it and resold it. Same exact medications, but now rebranding it as weight loss medications. But I think we see the uptick or the change in how the fat has grown based on how insurances have covered or chose to cover it. So originally, not covered as much. That's usually how all medications or how drugs are when they first come onto the market. Insurances are really slow to approve it. And so the ones that were started on it would have been the ones that were very niche or the ones that had really good health insurance. So then that started the fact, and so no one was talking about it at that point. But then once insurances started to approve it, because then they started seeing more data, seeing the benefits behind the weight loss, seeing that it does lower risk of heart disease, it does improve kidney function, and we're constantly still seeing more benefits as more research comes out. But as that insurance coverage became more broad, that's when we started to see more people on it. And then, of course, after the initial hesitation, because it is an injection, a lot of people were very hesitant to self-inject. Once they got over that, then everyone was on it. But then, again, as a physician, I remember about 1 or 2 years ago, there was actually a phase, almost a span of 6 to 9 months, where there was actually a shortage because everyone wanted to jump on it. And so that was a small blip in the timeline where the manufacturers were just not making enough of the medication to go around for everyone. And so that then bled into the introduction of compound pharmacies. So pharmacies that are not from the original manufacturers, who are then now trying to utilize the same sort of formulation, but not exactly as the original drug was created. So some slightly different. And I know you did a little bit of research on looking into that. So I'm curious to see what you found on the compounding pharmacies.
When I heard compounding pharmacies, at first I thought to myself, well, what does this mean? So I actually went to our handy dandy chat GPT, and we've talked about this in our AI episode, but I asked, explain compounding pharmacies to me like I'm a 12-year-old. literally like I'm a 12-year-old. And the example that it gave was a pretty good example. It said, normally what you do is you go to the store and you buy pre-made cookies. Buy these cookies, you take them home. They already have everything in it. You put them in the oven and you bake the cookies. And that's all you have to do. And at the end, you have a nice crisp cookie and you don't have to do a lot of work. There's another route to making cookies, and that's you making cookies from scratch, where you go out, you buy all the ingredients, you put them together, and then you are able to make your own cookie. You can make them taste to your liking. You can include more sugar, less sugar, more chocolate, no chocolate at all, so on and so forth. So from my understanding, what these compounding pharmacies do is that they have the ability to create medication from scratch and then alter the medication specifically for individual patients. So it'd be the same manner of, I need this type of drug, and maybe your child has trouble swallowing a pill. So instead of being able to put it in a pill form, they're able to put it in a liquid form, where now that same drug is able to be taken by that child and have the same impacts. The compounding pharmacies, they have restrictions from the Food and Drug Administration as to what they can and cannot do based on this making from scratch. And so some of the regulations come with, are they using the exact, and I'll call it recipe, quote unquote recipe, that a commercial brand is using? Are they actually taking the IP and creating an exact carbon copy of that medication? Well, you can't do that. Are they trying to mass produce something? Well, you can't do that. So the limitations on compounding pharmacies are very specific in order to make sure that they're doing right by their patients, but they're also not becoming so overbroad that they're either messing with the market, they're messing with the intellectual property, and so on and so forth. Is that what your understanding is as far as a doctor goes and what you've had to deal with as far as pharmacies?
You got it. It's basically a boutique for drugs. You go in and you get to make your own combination of different types, different formulations. Another example would be going into a perfume store and creating your own perfume. So it's the same thing. You go in and there's specific drugs that you need and you want it to become for certain formulations. Compound pharmacies are able to, majority of the time, create those things. If you want to combine several different types of pain medications together, they may be able to do that. Several different types of ointments together, they can do that. So there's definitely a time and a place. And I'm curious to see if you saw more negatives or positive out of it. But from my standpoint, the one thing we worry about from the medical side is, yes, the basic foundation of what the drug is there, but what they're utilizing to, what's the term? What they utilize to formulate, again, it's not the exact recipe, is that going to be detrimental on how it affects the patient, how it works, and long-term effects on the patient? Because we know the data behind the original recipe from the actual manufacturers, their data, we can see the pros, the cons, but these compounding pharmacies, we have no idea what that data is because they're not doing any research or data on it.
It's not just the compounding pharmacies. There's also a larger conglomerate of, like, I know I'm going to not use an appropriate term, but it's almost like prescription mills. They're manufacturing companies that are able to put together mass drugs in the same way a compounding pharmacy would be able to do so. And then they have certain rules and regulations as to how they can distribute it. Mostly it's to hospitals. But you have these two branches of individual or conglomerate pharmacy business putting together the quote unquote recipe for a drug. But then the regulations come into play when you're looking at safety and quality control. Are these being marketed as counterfeit products? Are they fraudulent? And then you also have the business side of it where I discussed this a second ago, like you're invading somebody's intellectual property, you're stealing someone's IP, and then you yourself, your pharmacy or your conglomerate that's working these is then getting a market share, a piece of the business when they really didn't do anything to earn that business. And then there's also preventing compounding loopholes and trying to get around it. We talked a little bit ago before about like the shortage that occurred. You had mentioned the shortage. And one of the main times compounding pharmacies are really leaned on is if there's a shortage. So when there's a shortage that occurs with the drug, the compounding pharmacies are, hey, you guys are up. The FDA says, you guys are good to go. Let's start making it. So then we can get back to where we need to be for all the patients out there. But as soon as the demand goes down, the FDA then turns around and puts their restrictions back on, saying, okay, you guys have to stop. You guys helped out, but no more. We are there. The commercial products are back widely available to the nation. You guys are no longer allowed to make these drugs anymore. And that's some other very interesting points that I found when I was researching the compounding pharmacies aspect of it.
Did you see the fact that there has been a stop now? There is a
Yes.
restriction on these compounding medications.
Yeah.
And so companies like hers, Hims, Bro, these are all companies that utilize that compounding aspect to sell the same sort of drug, but slightly different. And that's how they were making their profits. The issue I find is that who's on the other side prescribing it? Who's keeping an eye out on the side effects, titration, making sure that there aren't any risk factors? Because again, we haven't talked about it quite yet, but there are things that are negative about the medication, whether that is side effects or increased risk of certain cancers. These are things that you really want a professional, specifically a physician, to make sure they're overseeing your care and your health and prescribing it appropriately and come on and off as needed.
And to that point, I did find a case that right now it's in Texas. So it was filed in the Northern District of Texas, which is federal court. And it is the Outsourcing Facilities Association the Food and Drug Administration. So the OFA versus the FDA. And what the OFA was doing is they were essentially a mill. They helped during the shortage. They were making this drug, helping out. Obviously, it's not brand name, but they had a market share. They were putting it out. Well, they ended up suing the FDA because they wanted to continue doing exactly what they were doing, which was creating the drug, marketing it, selling it. And so essentially the FDA put a stop, and it's going through the courts. And at this point, it's been appealed because the court turned back and said, you guys have to follow the FDA. The FDA has stopped you guys from doing the compounding of the drugs. There's no longer a shortage. You guys need to stop. And so the OFA does not like that very much because they want to continue doing exactly what they were doing. So that was one big legal case that I saw, and it's going to be making its way through the appellate court system because OFA does not like what the lower courts had to say. And that's what you do. If you don't like what the lower court has to say, you try to appeal it and move your own way up.
That's not necessarily a good or a bad thing because, again, you can see both sides.
Yeah.
The good thing about compounding pharmacies and the readily available use of these medications or prescriptions is that the cost usually comes down when a lot of competitors are able to create it. However, the concern is, again, the original recipe. We have a lot of data behind it supporting it, but when you tweak the recipe slightly, is it going to still give the same exact outcomes and effects? You may get the short-term effects that you want, but what are the long-term concerns?
Health and fitness and fads, it's always there. Everybody wants to achieve the ideal healthy lifestyle, the ideal physique. It reminds me of when people really get into lifting weights and athletics. There's all these supplements that you can take. You can take these proteins, you can take the creatines, you can take the vitamins. There's all these supplements out there that exist, but then you look at these and it's like not FDA approved. So all these standards go out the window, and you're looking at what kind of impact is this going to have on me? Are there going to be side effects? I'm very big into mixed martial arts and combat sports and boxing. And there have been several times where you hear of athletes getting popped for steroid use because they take a protein that just so happened to be made in a facility that was also making steroids. Somehow things got mixed up, and then they pop hot, and now they're suspended or their license is revoked from being able to compete. It kind of goes to like, well, there's certain standards that must be abided by per the FDA that allow it to be more reputable, allow that brand to have a better reputation. And you know what you're getting. You know what you are getting when you're taking that specific prescription.
Yeah, and standards. That's a good segue into discussing what are the things that we should try to keep an eye out for or things that should be avoided. These medications should be avoided in patients who've had certain conditions. So the standards are there. These are what the manufacturers have put out as concerns or could be causations, correlations. Time will tell. We still don't know quite yet, but these are the reasons we want to keep an eye. So one, majority of the medication is utilized in type 2 diabetics. So we usually do not use it in type 1. Again, doesn't mean we can't utilize it in type 1 diabetics, but you really want to have that conversation with your doctor to determine if you're a candidate. Another thing is if you've had a history of pancreatitis, this medication can increase the risk of pancreatitis. And that is an organ that is right next to your stomach. So it's going to be what we call epigastric abdominal pain. So pain right in the middle of your chest there. That can be a signal of pancreatitis if you're on this medication. Pancreatitis can also be due to gallstones. It can also be due to alcohol, a whole slew of other issues as well. But because you've had this history, it could increase your risk of developing it while you're on the medication. And it's not fun. You usually have to go to the emergency room and you usually are hospitalized for it. Other things that you want to keep an eye out on or have on the back of your mind is that this could increase your risk of medullary thyroid cancer. So, the one question I always ask my patients before we start them on it is, have you ever had a history of thyroid cancer, or do you have a family history of thyroid cancer? Most patients who know they have a family history can usually tell me, yes, I have thyroid cancer, but they're usually not able to tell me exactly which type. There are different types of thyroid cancers. So just because you've had one type doesn't mean you can't take this medication. But again, a conversation that you really want to have with your physician. And that's why it's so important that not only are the standards there, but you have someone that is prescribing, that is watching you and looking over your shoulder constantly. The other final thing that I always want to make sure is that, are you at an appropriate age or weight to be on it? Someone that is frail, someone that is older, do I really want you to lose more weight just to control your diabetes? Probably not. Again, we got to be really careful about who we're prescribing this to. And that's why it's really important that anyone out there that is willing or wanting to take up this medication, that you have this in-depth conversation, but you also do your own research. I am absolutely not against this medication at all. I love the medication. I feel like it's done so much great things for my patients, and it truly has changed a lot of their lives, especially the diabetics.
So, as far as other goes for the medication, some of the things that I saw was reduced risk of stroke, reduced risk of like liver disease, protecting heart health. So, even if somebody is, let's say, not frail, but not necessarily obese, would you still, and I get everybody's different, would you still think that there'd be benefits to taking it in order to help those other things? Maybe not specifically attacking the weight loss aspect of it?
So again, great question. So this is where, as we process the data that comes out from the companies, you have to make sure that you analyze it appropriately. So yes, the medication shows a correlation of reduced cardiac risk, improvement of kidney function, all these health benefits from the medication. But is it truly from the medication, or is it because they're losing weight while on the medication? Because obesity increases those risks. So of course, if you're going to lose the weight, it's going to improve those things as well. So this is where more data is needed for us to call it a causation. Right now, we're calling it a correlation. Of course, the manufacturers are going to try to sell it as a causation. And honestly, at this point, I don't think it truly matters that much, because if the patient is benefiting from a weight standpoint, but as well as a cardiovascular standpoint, it's all, let's take it on. Healthier community, healthier society is always better.
So, correlation causation. Question for you. Another question that leans on that idea. One would assume that if you are taking GLP-1 for weight loss, you are also probably living a healthier lifestyle. As far as you're eating healthier, your meals are probably smaller. You are probably more motivated to go work out because you're losing the weight, you're seeing results. So now you're getting back in the gym, or you're going on walks, you're going on runs. So is the healthy lifestyle aspect also needed? Is there correlation there, or is one causing the other?
No, it's absolutely needed. I have a lot of patients who are on the medication, but still eat unhealthy, still choosing the wrong foods, and still choose not to exercise. So you do need the full treatment plan for it to work and be effective. Yes, the medication is going to do some of the heavy lifting. It's going to curb your appetite. It's going to make you want to eat less, but it's not going to force you to eat the right foods. You can still go out and eat burgers. You might not be able to eat the full burger, but you're still going to eat burgers every single day. That's still going to be very unhealthy for you. It really takes the full picture and the full treatment plan to make this a truly successful drug for you and your life. And that's where it's important to also keep in mind that these medications are meant to take long term. Supposed to be a lifelong medication. A lot of people think of obesity as something that's just transient, but obesity truly is a disease, just like high blood pressure, just like diabetes. It's there and it's staying there. It's something that you have to constantly control every day. And therefore, if you're starting a medication for high blood pressure and you're starting a medication for diabetes, it makes sense that if you're starting a medication for obesity, that it's something that you stay on indefinitely.
I'm going to press you on that. If you need to go eat healthier, you need to go work out, then why take it in the first place? Why take the GLP-1? Why not do the other things first? Or is it that you've done those other things first and the GLP-1 is assisting on the side, saying, oh, you couldn't get there with just changing your lifestyle? I'm going to give you some help.
It's the assistance. I personally feel like it's from the psychological side, especially for when you're taking it purely for weight loss.
Mhm.
A lot of people who are motivated, they'll go out and they do everything, but their body just keeps fighting them and they're not shedding the weight. So this medication comes in to help that. There are also people who are not motivated enough and they need a kick, something to just light a fire. And this medication can be that fire. So it can start the process by getting them motivated. They see 4 or 5 pounds lost in the first week or two. It may motivate them to exercise more because the medication has started the process already. So it's multiple reasons why this medication would work and could be utilized for a lot of people.
So
And that's why it's important that you use everything.
yeah. So you have a patient that walks into your office and they say, I'm overweight. I would like to lose weight. I would like to, try out Wegovy or Ozempic. Are you saying, all right, let's go? Or are you walking them down the line of, hey, let's make some changes first and then let's come back and revisit it? What's the general doctor approach? I know you're not speaking for all doctors, but what is the general doctor approach that you would take?
My general approach is, again, I want to always try to push natural as much as we can. So I'm going to urge the patient, let's work on lifestyle changes, exercise, portion sizes for at least 2 to 4 weeks. If we're not able to lose 1 or 2 pounds, let's consider the medications. However, I'm actually not the one that is limiting their access to it. It's the insurance. So believe it or not, the majority of people's health insurances do not cover weight loss medications. It's about like 90, 95%. It's very rare for us to be able to get um, these medications covered for weight loss. Now, if you have a diagnosis of diabetes, it's usually 95, 100% coverage if we can find the right brand that they'll cover. So again, we've talked about this in past podcasts, is our health system is very much a reactionary health system rather than a proactive health system. Rather than focusing on how can we prevent disease, we're reacting to those disease processes. Right now, the insurances are not covering obesity, but they are covering for diabetes. And so yes, I'm totally fine prescribing it, but the discussion will always be, let's work on diet, portion size, exercise, see how we go from there. And then let's see if we can send this into insurance if it's covered or not. I will also give them other options. There are other weight loss medications out there on the market that we could utilize that are usually cheaper, things that you could pay out of pocket if needed. But again, they're not as effective. And that's anecdotally, but also the data shows that they're just not as effective. But for someone that cannot afford $1,000 a month for these injections, those orals might be the only other option that they have.
It's such a wild thought to think that from an insurance standpoint. And I get there's a lot of fads out there, and insurance probably doesn't want to cover every single fad. But when you have something that's working, the data is still coming in, but the data thus far has been really, really good. Obesity causes a lot of problems down the line. And we've talked about several of those issues up to this point. You'd probably be able to prevent so many different health issues if you just invested in the initial Ozempic. You allowed your patients access to that. There might be some people out there that put on their tinfoil hats and say, well, it's big pharma. It's all the money that you can get from having your people sick, even if it's not a terminal illness, but having somebody come in for medication, having somebody always have to come in to see their doctor every month, every couple months. Like there's a market for healthcare, obviously, but it's the access to something like this and what you had just said, where it costs a lot of money, and that are demographics that are lower socioeconomic, they're more impacted by obesity. And so the fact that they can't have access because of how much something costs is definitely concerning. And then the vicious circle of, well, they're just going to get more sick and there's more problems. And this problem leads to that problem that leads to that problem. And that's just like the circle of life at that level. It's hard to swallow.
It's something I see every day. And that's why I urge so much that, yes, we can do this medication, but we really have to try to focus in on the lifestyle changes, because that's really what's going to lend us for a better future. Because I'm sure most people's goals are to get off these medications. But again, majority of the time, you have to stay on it lifelong. But for the ones that are truly, truly motivated, I say the only way we're going to get to that point where you can come off is if you change your mindset around around food. You're eating less, your portion sizes. Again, I've just been reiterating the exact same thing we've been doing here on the episode. Is what I do in my office is I reiterate every time the patient comes in. We're going to keep working on this thing so that we can try to get you off. However, there are things that we can do. We can lower the dose to a maintenance dose. So once you get up to the goal weight loss that you've achieved, then we can always lower the dose or microdose the medication so that you can still maintain, but you're not on as high of a dose. So there are options out there. But it's always what a lot of patients say is that that hunger signal or that food signal gets turned off or gets turned really low when they're on the medication. But as soon as they come off, it jumps right back. It goes from 1 to 100. And so then they're eating so much more.
We do our research before we have these conversations, and I was watching a YouTube video with a fitness trainer, and he was talking about taking Ozempic, and his thing was, I want to understand what my clients are going through. And so over the first 2 or 3 months, he cycled on, then he cycled off. And one of the things that he had admitted to was the fact that he had always had a problem with food. But because of his approach over the 3 months, the healthy food choices became more habitual. He wasn't reaching for the cookies. He was more aware of what he was doing. He was more aware of the times that he wasn't actually hungry and the times that he was just reaching for something because he was bored. So to your point, it's creating that healthy relationship with food and then being able to carry it on and really make it a habit. That way you can see the results from all your hard work.
Mm-hmm. Mm-hmm. And again, this medication, I get there's going to be a lot more indications to be used in the future. Over the last year or two, some of the brands have been approved for sleep apnea. They're coming out with other reasons to be utilizing these medications. So time will tell to see where we're going to head to.
So I was going to say that might be a good transition point because you mentioned the sleep apnea, and I have a question for you. I'm not, an expert on the FDA process, but if we were going to walk through the FDA process, essentially, identify a need. I want to solve this problem. I want to fix this. And then you start looking at, okay, how do we get there? And it can be one of 1,000 different ways to get there. At that point, once you can identify it, you're then taking it through a preclinical process. You're testing that medicine against cells. You're testing on animals. Then you're moving into testing on people. And so you're going through clinicals. You're working with people that are healthy. You're working with people that actually have the thing that you're trying to help mitigate. And then eventually it gets approved if it's, doing what you say it should be doing and the side effects are not invasive and so on and so forth. So do you have to, like for sleep apnea, would you have to run through an entire FDA process all over again to then take that and say, all right, we're going to use it for sleep apnea and then get that to be a certain brand and then market it as such? Are you aware of that at all?
So my understanding is that as they're going through these different trials, they're not just focusing on the data points that they're looking for. They're also collecting data across the board for a lot of things. And then at the end, when they're reevaluating and putting all their numbers together, they may see other correlations or other paths that then they will want to pursue further. So I'm assuming that originally focusing on diabetes, and then they realized weight loss, and then eventually probably saw sleep apnea, because again, these are all tied very closely together. Obesity can lead to diabetes, but obesity can also increase your risk of sleep apnea. And so it just makes sense that this might be the next stage or next effect or benefit. And so then they have to go back and prove that by doing more data, gathering more research, etc.
That makes a lot of sense. The process takes so long. What I saw was it could be 6 to 10 years just to get through clinicals. And that is a long time, especially when you have people that are sitting there waiting for that help, that are waiting for that pill, that are hoping for a solution to their medical problems. That's such a long time. But obviously, you want to make sure that that standard is met, that that quality control is met, and that you're just not kicking things onto the market anytime you think it might be okay.
And I'm sure you've seen this. That's where there's regulations for a reason, because when things go onto the market and then there are side effects that they may not have foreseen, or things that, what we call post-marketing black box warnings. Those are things that come in after the fact. Patients are now struggling with issues, having major side effects, poor outcomes. Then the brand has to go back and pull it off the market or make sure that it's on their warning labels, et cetera, et cetera. So it's really important that we go through this process. But even when these medications go through the process, sometimes there are still things that we miss. And that's why it's so important. And that's why it's so rigorous as well. And imagine though, the ones that we see on the market are 1 out of 100 or 1,000 medications that have been tried, and we just don't see those ones, and we don't hear about it.
From my understanding, the FDA involvement does not start when the medicine goes to market. They actually continue to monitor. And I guess that there's instances in which medical staff or physicians can then start doing reporting based on the side effects that they're seeing to then again gather more data points to see, okay, over the long term, are we seeing something different, or is this consistent with what our clinicals had put out and what we essentially wanted this product to do and solve?
One of my mentors in residency or medical school used to say to me that you never want to be the first person to prescribe the medication when it first comes on the market, but you also don't want to be the last person. So it's finding that happy medium, but also it's so important that you're staying on top of this data. There are a lot of older docs that are not comfortable with these medications because they just haven't read the data, whether they're too busy, whether they're too tired, they're just not up to date. It's really important that you find a physician that you trust that has done their own research as well, because this data comes out, it's constantly changing. You want to make sure that you stay on top of it.
And is that where pharmaceutical reps come into play, where they're coming to the office, they're trying to give you literature, give you samples, push their product, and then it's on you as a doctor to say, oh, yeah, that could help, or no, I'm absolutely staying away from that?
You got it. Yep. So pharmaceuticals are definitely to push their product, and that's why you always have to be very skeptical. You got to do your own research. Just because they're dining you, giving you a lot of these perks, doesn't mean that you go out and just prescribe it. You're not doing your patients right if that's the way you're doing it.
And so I know a few minutes ago I brought us down a certain path. Is there something you wanted to add to that?
No, no, I think we've done a very good summary of what the medication does, the effects, the benefits. It's really hard to determine whether or not the medication is causing some of these benefits or whether the weight loss is. Doesn't matter what it is though, because if it's benefiting our patients, I'd like to continue it, and I'm glad that there are no longer shortages at the moment. But at the end of the day, I do find patients that would benefit from this the most tend to struggle with the cost because, again, insurances may cover a portion of it, not all of it, or maybe they're not willing to cover the specific brands. It's really frustrating when we're in the patient room, we're trying to have this relationship with the patient, and you know this medication would work best for them, but then there's this middle person that says, no, we're not going to pay for it. That's always going to be a struggle here in our system. I'm hoping that one day it just becomes better. And that's where, when we started talking about compound pharmacies, they work kind of um, an open door for that to help bridge the gap there, but then safety issues, safety concerns.
To your point about shortages and there not being a shortage anymore, it's even in the news now that Costco and Costco Pharmacy is going to be selling Ozempic and Wegovy. I have a deal now where essentially, and this isn't over the counter, you have to go get a prescription, you have to bring that prescription up. But if you are uninsured, then it costs about $500 for a 1 month supply. If you are insured, then obviously you have to go through insurance. Or if you're attempting to use insurance, you got to go through insurance. If you were just going to pay, what they call cash, which is now debit, credit, whatever. But if you were just going to pay for it yourself, it's $500 and you get a month long supply. It allows for better access because everybody respects Costco. Everybody loves the Costco brands. So although it's not a Costco brand, when you're going to the Costco pharmacy and they're giving you Ozempic, you're saying, okay, I'm getting the real deal. I'm not getting a fraudulent or a counterfeit medication. I'm getting exactly what's being prescribed to me. I'm not worried about some small town pharmacy that's compounding stuff behind the back. I'm actually getting the name brand. That's important for access. But then it also goes against the kind of socioeconomic issues that we were just talking about, where not everybody has a Costco membership. For Costco, you got to pay for entry, essentially. And if you're not going to Costco, you might be going to Sam's Club. If you're not going to Sam's Club, you may not have a grocery membership and you're just going to your neighborhood grocery store or your neighborhood pharmacy. And so I like the fact that there's more access and they're finding a way to negotiate the cost of this medication cheaper. But there's still those dilemmas and delays that occur because of where it's coming and how much it is. And to your point, whether or not insurance is helping out or if they're not helping out.
Are you seeing, when you did your research, did you see that this was specifically for Ozempic because they are trying to do a better job marketing? Or what is your take on why they're doing this? Because I'm not sure if you saw, but a competitor's brand who does the same GLP-1s once weekly, they actually have a program where you can go directly to the manufacturer, and instead of the medication coming in a pen where it's an auto injectable, where it's easy to use, they can come in a vial instead, and they have to draw out the medication themselves. But that, if they get it directly from the manufacturer, comes down to the price of $400, $500 a month as well. So I'm wondering if Ozempic is partnering with Costco to compete with this other brand.
I didn't see the notes about the competitor, but that would make sense. If somebody's able to give you a more cost-effective rate, then you got to find a way to compete with that. Obviously, the medication is not being sold at cost. There's still profit that's being turned. But I would assume that if one company does this, it's going to push the standards of the direct competitor. And what's better than being able to go into a Costco on Sunday with the family, get your prescription, go wait in line, get your Costco hot dog, and get all the samples? Like, that makes everything so much easier. And then they one up their competitor by saying, we'll give you the real product for the same price. You don't have to worry about pulling it out of the vial yourself. It's just there ready to inject. That's a very interesting point. That's why I actually love competition, because competition really pushes the cost efficiencies. I'm not a big fan of a certain company having a monopoly over everything. That's where problems arise. So I'm interested to see that, the fad, it was this year, last year. I'm wondering where it's eventually going to go. 2 or 3 years from now, is this going to be such a revolutionary product that it's the number one go-to for everybody? Are we going to find that there were pretty adverse side effects and you're starting to see all the lawsuits come out of the woods and everybody's getting sued for billions and pound billions of dollars? Is it just a fad and it's going to disappear, and before you know it, no one's going to use it? I'm interested to see where it goes.
Legally, though, I have a question. Legally, with Costco taking on this venture, does that put any sort of liability on them at all? Or is it just them selling a product, and if anything comes of the product, it's on the product, on the brand, not necessarily Costco?
When it comes down to it, we've talked about this many times. You sue everybody. You sue absolutely everybody. So if something happens, you sue Costco, you sue Ozempic or Wegovy. Their parent company is Novo Nordisk. I want to say it's like a
You got it.
Scandinavian company. And then you're suing that company. But there's also these weird situations of suing a company that's based internationally. And we don't have the time to go into that today. Laws in a different country do not apply here. But if you were to sue somebody in a different country, or an entity in a different country, there's a lot of different things and wonkiness that can happen there. So I'd be interested to see who would end up being liable at that point. But again, you're suing everybody. And that leads into a question for you. I don't think we've discussed this. What are those negative side effects that you're seeing? We've talked about the positives, but what are the negatives? I've seen some gastro issues, but I've also seen blindness and severe diarrhea and surgeries on your pancreas. So what are the negative side effects that everybody's looking past with these medication?
Just like any medication out there, there's going to be a laundry list of side effects that could potentially happen. If it happened in one person, the manufacturer is going to put it on their label as a potential effect. So blindness, again, we're not seeing it widespread. So we're still waiting for the data to come out to see if it's truly from the medication or not. The most common side effects that we're seeing are all GI related, so gastro related. Because your system is slowing down its metabolizing and digestion, you're going to have increase in acid reflux. You're going to have increase in constipation, most likely. You may have what we call sulfur burps, where you burp these really, really foul smelling burps, and it's because the food's sitting in your stomach for a lot longer. Constipation can then lead to obstructions. It can lead to certain abdominal pains, hernias, hemorrhoids. These are all potentials. Not everyone deals with it. And I would say the majority of people don't have these effects on the lower doses. It's when they start titrating up in doses that they start to feel it. Now, that is the most common, constipation. The opposite can also happen, which is the severe diarrhea. There are some people out there who cannot tolerate it at all, because instead of the medication slowing things down, it actually just causes them to release everything immediately. And so, again, a conversation to have with your doctor. If you're having any sort of GI related symptoms, cramping, nausea, vomiting, anything like that, it's important to discuss it. But another thing that I'm seeing ancillary to all this is that if you're not eating as much, or one, you forget to eat completely altogether, you may get lightheaded, you may get dizzy, you may pass out, because your body still needs calories, it still needs energy to operate. So this medication can be so good at turning off that hunger signal that you forget to eat all day. And that's where I really make sure I tell my patients that you gotta make sure you eat regularly and just do small snacks throughout the day. Even if you don't feel hungry, you gotta feed your body. And then the final side effect is that this medication is great at losing weight, but it does not discriminate between fat versus muscle. You're gonna lose a percentage of your body weight, but it's not gonna say, oh, I'm only gonna lose body fat. And so it's very important that when you're on these medications, I talk about increasing your amount of protein so that you can feed your muscles, but then you also want to pair it with strength training. So it's really important that you go out and you lift weights, or you go out and do body weight workouts to maintain the muscle mass that you have so that you don't also lose it. I think that's also a great place to end here, Lawyer Nik. I think it was a really good conversation about GLP-1s, which is so important and so innovative that I truly do see this taking us in really great places for the future. But this is the Medical Legal Brief, where we talk about medicine and law. And so if you're interested and you want to hear more, check out all the other episodes that we have on Spotify and YouTube. But please leave us a like, follow us, comment. We love to interact with you. And if you have any new ideas or other topics that you want to hear from us, let us know. Send us a message and we'll definitely consider it. Dr. Long and Lawyer Nik here. Yes, we're doctors. Yes, we're lawyers. No, this podcast is not medical or legal advice. Do not take anything we say as a reason to perform your own heart surgery, represent yourself in court, or diagnose your neighbor's rash. This is for entertainment only. Think of it like hanging out with your smartest, wittiest friends, not a substitute for an actual appointment. If you act on anything we say without talking to your own professional, that's on you. Seriously, don't do that.